So thank you to the organisers for asking me to come and talk today. I was given the title of Women in the Field of MS, which I agreed to talk about a while ago. And then when it came to writing the slides, I actually started to think, well, what am I actually going to talk about? So disclosure slide, I think my main disclosure really is that I'm female, and that's probably why I've been asked to talk about this. So when I started to think about this, I thought, what do the chairs want me to talk about? And I suspect they wanted me to talk about women in science. What does everybody in the room think about I'm going to talk about? I don't know, and maybe you don't know either. But what I'm actually going to talk about is sort of a bit of a broad overview about how we can actually use the gender, the sex ratio in MS to think about MS susceptibility, and then some stuff about women in science as well, which is of particular interest. Managing expectations, what I'm not going to talk about is pregnancy and its impact on MS, and MS on its impact on pregnancy, because you've got a number of talks coming up subsequent to this that really cover that in far more detail than I would ever be able to. You'll hopefully be reassured here also that I'm not going to talk about in-depth biochemical pathways that are affected by sex hormones, although I will be touching on this as part of my talk. So when I sat down to think about this topic, I was trying to think about how we can actually use sex-specific characteristics to better understand MS, MS risk and MS epidemiology. I think everyone in this room knows that the sex ratio in MS has been changing, that there is a sex ratio in MS, it's not one-to-one females to males, and that MS behaves differently during and after pregnancy. It's long been held that there are differences in disease characteristics between men and women, although the underlying cause or the underlying etiology of these differences in disease characteristics is really not well understood. The most obvious candidate has historically been sex hormones, but as I'll come on to discuss, there's quite a lot of evidence or quite a lot of research out there, but it doesn't all add together in a nice, neat way. So traditionally, estrogen is thought of an anti-inflammatory hormone, but if estrogen is anti-inflammatory, why do more women get MS than men? And again, testosterone is neuroprotective, and I'll discuss that in a bit more detail. And finally, as was alluded to this morning, and Professor Wauban talked about, this change in the sex ratio of MS in paediatric MS post-puberty. So prior to puberty, the sex ratio of MS, of paediatric MS, is about 1-to-1. Post-puberty, you start to see this huge, huge difference between males and females in terms of risk emerging. When we think about MS epidemiology and MS etiology, genome-wide associations and the genetic architecture underlying MS are an obvious candidate. There's actually been until the most recent GWAS, there's been no attempts to study MS-related susceptibility linked to either the X or Y chromosome. In the most recent publication, they were able to identify only one single nucleotide polymorphism on the X chromosome, and this was an enhancer peak associated with T cells with unclear functional consequences and certainly not involved in actually sex-specific characteristics. No SNPs associated with MS in any way were identified on the Y chromosome. And actually, of that single SNP, the odds ratio were not notably different from others that were identified throughout the rest of the human genome in the genome-wide association studies. In addition, there's actually been work on EAE mice looking at mice with truncated Y chromosomes to study maternal versus paternal imprinting, which is obviously very difficult to do in humans. And there does appear to be differential imprinting depending on where your chromosomes inherited from between mother and father. So we don't really have a genetic basis that appears to underlie the sex difference that we see in MS. So just briefly to cover this, so the sex ratio was approximately 1-to-1 in 1900 if you go back to historical studies. And ever since 1900, there has been this emerging sex ratio in MS. Women are more likely to get it than men. But I did some sociology earlier in my training, and I think we have to take this in the context of improving healthcare for women. We can't assume that healthcare has been the same for men and women since 1900. We know that it hasn't. Access to healthcare has been very different, and the ways that men and women are treated within the healthcare system has evolved over the past century. So any increase that we see in the sex ratio has to be taken against that background. Having said that, when you actually look at incidence of MS, and this is a sort of brief literature review that I did as part of preparing this talk, it's actually not entirely clear that there is an increasing sex ratio. So studies from Ontario, from Sweden, and a prevalent study in New Zealand showed no change in sex ratio since 1950, whereas studies that either go further back or sort of smaller studies do show a change. So I don't think the evidence is definitive that this is there, although it is generally accepted that it is. But can we learn anything actually from the variation within studies? So you have this huge variation within the studies, they're not saying the same thing, but actually that's interesting in itself. So this is work done using MS-Base, where they actually use the differences in sex ratios between different countries and the latitude of those countries to try and really drill down and say, does this difference tell us anything? Because going back, there does appear to be some kind of geographical relationship, although that's quite different from the geographical relationship that's seen here. So in the MS-based studies, what appears to come out is that the more northerly you are, the increasing sex ratio is seen, whereas studies that are based more around Southern Europe don't see this change. But this isn't happening with everyone with MS. The sex ratio of primary progressive MS is remarkably stable, whereas it's really relapsing remitting MS where we see this change. So if there is a change, and I think there probably is, what could actually be driving it? Given the latitudinal gradient, vitamin D often comes out as the top idea, the top hit. Actually, what evidence is there to support or not support this? So there's no established difference between serum vitamin D levels between men and women at a population level. And actually, when you look at large epidemiological studies, the odds ratio is associated with vitamin D being protective, are the same between women and men. So the 27 reference is the Finnish maternity cohort. The 2006 reference is the US veteran studies, which although not 100% women was predominantly, not 100% men was predominantly men. So it's not actually levels of vitamin D. That doesn't seem to be, at least at a population level, what's driving this change. However, the more interesting question to my mind is whether vitamin D actually interacts with sex hormones and whether this is driving some of this. And there's quite a lot of evidence around this, partly from the MS literature and actually partly from the oncological literature as well. So vitamin D appears to act as a paracrine hormone. It decreases aromatase expression, which in turn influences estrogen synthesis from androgens. And estradiol itself, one of the downstream results of increased estrogen synthesis, increases vitamin D expression and so enhances the downstream effects of vitamin D. So there is actually a positive feedback loop around estrogen and vitamin D. Work has been done in EAE models, so in mouse models, to try and drill down into this a bit further. So this study used dietary supplementation. So these are mice that are being fed vitamin D prior to induction of EAE. And this first graph just shows that the animals get a pretty consistent response to having a vitamin D supplemented diet. In mice that are susceptible to EAE, then in the females, you actually see an attenuation of EAE severity scores in those in the high vitamin D group, but not in the males. And these are mice that are not so susceptible to EAE, but even in the vitamin D deficient group, you see some propensity towards EAE, which isn't seen in the men. So it implies that there appears to be some kind of sex-specific response to the same levels of vitamin D. First graph shows these animals are getting the same levels of vitamin D between men and women. Further work they did in this study shows that this is not directly mediated via calcium. There's been concerns around mouse models of vitamin D and actually some of the effects being mediated via calcium. Because in mice, if you very highly dose them, and the same as humans, they get very high calcium levels. However, these mice had the same calcium levels in both the high and low supplemented groups. And this does appear to be estrogen dependent. So these are mice who are either high or low vitamin D, have normal ovaries, so normal physiological levels of estrogen. If you take out their ovaries, so you reduce their estrogen, you lose the difference that seems to be induced by oral vitamin D supplementation. If you remove their ovaries and then feed them estrogen to try and replace those physiological levels, that seems to come back. What could be the mechanism of this? Well, as I said earlier, vitamin D enhances the biosynthesis of estradiol, increasing vitamin D expression. So you get the two acting in synergy. Do you get a greater effect, in inverted commas, of vitamin D in women, at least around the time of puberty? Or does vitamin D deficiency have a greater effect in women? I think those questions remain unanswered. There is some evidence from humans. So these are using purified T cells from people with MS. And actually the concentrations of vitamin D that are required in vitro to inhibit 50% of T cell proliferation are much lower in women. So again, it's pointing towards there being some form of sex-specific effect. And this appears to be happening via the estrogen receptor. So these are, again, purified T cells resting. If you add vitamin D, so in the absence of estrogen, in the presence of progesterone alone, but no estrogen, in the presence of an estrogen blocker, an estrogen receptor blocker, or an estrogen, and then these are alpha and beta receptor agonists, then you see differential effects. There is something about estrogen that appears to be driving this effect. Well, if it's all estrogen, then maybe, we come back to this idea about puberty or about menarche in women with MS. Again, the literature has historically appeared to suggest that MS is associated with earlier menarche. Each 1 year increase in age of menarche gives about a 10% reduction in the odds of MS. So the later you hit puberty, the later you start your periods, the less likely you are to get MS. And this, again, is supported by the observations around the sex ratio. However, more recent Mendelian randomization work has questioned what the underlying etiology behind this is. So in this work, the authors looked at the effect of genetic influences on age of menarche, and then dissected out how much of that appeared to be related to obesity via genetic influences on obesity. And actually, they argued that if you take out all the BMI increasing SNPs, you lose the effect of menarche on MS risk. So actually, is it not menarche? Is this association with the age of menarche, is it all being driven by adolescent obesity, which, as we know, is an important factor in MS development. So again, Mendelian randomization supports the influence of childhood obesity on MS risk. This is work that Ben Jacobs has done, which has just been published. It appears to be independent of the relationship between obesity and vitamin D. So you get an influence of vitamin D, you get an influence of obesity, and you get an influence of vitamin D, and these two seem to be affecting MS differently. So whilst maybe obesity interacts with menarche, it doesn't appear to interact with the vitamin D pathways. So coming back to this potentially changing sex ratio in MS, could obesity be implicated? This is WHO data, and this looks at increasing rates of severe obesity. And this is men, and this is women, and the scale is the same between the two graphs. And to me, this was terrifying and hugely striking. We have an obesity epidemic within women throughout the world, and particularly this is Europe, and this is America. So we have this hugely increasing rates of obesity in a population who are on average quite vitamin D deficient. And there are actually sex-specific downstream effects of obesity. So obesity is associated with high estradiol in both men and women, but actually there appears to be differential gene expression within adipocytes between men and women. This is a particular area of interest within the cancer literature, and if anyone's interested in this, I'd suggest you go out and sort of start reading the cancer literature. There's a huge amount out there, because actually estrogen secretion by fat cells in postmenopausal women is strongly associated with breast cancer, and there's an epidemiological association. There's also biological associations. So this is something that's being studied in other fields that I think really in the MS field we're being slightly slow on the uptake about. Estrogen's associated also with obesity development in women. So again, you get this positive feedback loop where your fat cells secrete estrogen. It's associated with the development of obesity, and then the downstream effects. There's also, and I think we do have to think about this as a population when we think about estrogen as an anti-inflammatory, the unopposed actions of this, which are essentially pro-malignancy, so associated with both breast and uterine malignancies. Changing tack slightly, smoking is another factor that's really been associated or suggested as a cause of the strong relationship or the strong change in sex ratio or the apparent change in sex ratio. We see a reduction in the sex ratio between men and women in smoking. But actually, when you come to think about this in terms of MS increasing and increasing more in women, this change in ratio is really driven by men stopping smoking more than women. So this should be driving things down. It shouldn't be causing the level of increase that we see. And this is data from the UK. So we can see smoking rates are going down. The gap is closing, but everybody's going down. What we don't know is we don't know about vaping. We don't know what vaping does in terms of MS susceptibility. We don't know how vaping acts. And actually, it's almost impossible to find anything about vaping and sex ratio in the literature. I had a look. I could barely find anything. However, smoking does interact with sex hormones again. It sort of all seems to come back to the same place. Smoking is very well documented to decrease fertility. If anyone is undergoing fertility investigations, one of the first things they're told is you have to stop smoking. It's directly toxic to ovaries, and it has anti-estrogen effects via a number of mechanisms. Been a lot about estrogen. What about testosterone? Actually, in comparison, it's quite easy. So there is a strong positive relationship between testicular hypofunction and MS risk using hospital data from the UK. And there's been evidence for prenatal testosterone levels driving subsequent MS risk. So the lower testosterone level you have, the higher your MS risk, which again goes towards a protective effect, a potentially protective effect of testosterone. Men with testosterone have men with MS have lower testosterone levels on average, but there is an effect of chronic disease on someone's testosterone levels, so it's not as cut and dried as it seems. There have been some pilot trials looking at the use of androgen gel in MS. I struggle to say they're positive, but there are some possible effects on PASAT and on brain atrophy, although the trial primary endpoint was negative. And there's a putative mechanism via Th1 to Th2 shift in preventing or reducing MS risk. There's currently a testosterone study recruiting in France. So what about sex hormones as add-on therapy? So this is what I could find via clinicaltrials.gov. So there's 2 randomized controlled trials of exogenous estrogens as an add-on therapy. One showed a significant effect on MRI outcomes. One showed no effect. One is currently recruiting. And we can't forget about these potentially harmful effects. I think when we look at the HRT literature, everybody took HRT, and now it's really quite restricted. So I think there are emerging concerns around this. And there's only really very small studies of testosterone. So sort of back to my first question, how does this relate to MS epidemiology? I haven't given you all the answers. I don't know the answers. Don't think anybody knows the answers. The interaction is so complex that it's impossible to summarize. It's not unidirectional. It's not simple. But there is differential prevalence between sexes of many of the risk factors that may interact with sex hormones. And again, back to the sociology, I think when we look at epidemiology, we're often guilty of missing a lot of the sociological factors that drive change. So you have to consider what you find from the numbers in terms of the wider influences. There have been hugely marked changes, particularly in female, I've put behaviour in inverted commas, I couldn't think of a better term, but it's not the right term, since World War II. You know, how our population actually acts has changed significantly. We've moved, women are far more educated than they were. On average, indoor desk-based work, and also reproductive choice has gone from a dream to a reality. People are having fewer pregnancies, they're having pregnancies later in life. Contraception is now widely available to women. And then other changes, increasing use of sunblock, skin cancer awareness, and also driven by the cosmetic industry and anti-aging. And I think this took off in women, it's now starting to take off in men. And alongside that, we've got pollution and increasing urbanisation. When thinking about differential effects of MS risk factors, I think biological sex is not actually the only aspect that we need to think about. And when asked to talk about women in MS, I thought, well, why just women? Why not sort of all protected characteristics, for want of a better term? So this is work that I've been doing looking at risk factors in non-white populations. And actually we show that the risk of MS in non-white individuals, so black individuals in East London at the age of 18 is 1.3. MS is not a white disease. It's not a disease of women. Actually, these things are changing, and I think we need to really actively consider this. And smoking appears to be a stronger risk factor in the non-white population. So it's not just about male-female. It's actually about considering difference as a whole. And so then, fine, MS causation. Well, what about MS-DMTs? And I think this sort of starts to move towards what the organisers wanted me to talk about. So one thing that's been considered is actually are our population in MS clinical trials representative of the MS population that we see? My impression was, and this is before actually going and looking at it, that women might be underrepresented because of concerns around pregnancy, fertility in clinical trials, but this isn't actually borne out by the data. What is borne out is it's more treatment-naive patients, but actually everything else comes out as fairly representative of an MS trial population. However, and this is work that Maria Hutchins and Riley Bove did, what isn't considered is actually whether drugs can have differential effects by sex. So we talked this morning about how children are not just mini adults. You know, they have different physiology. Your physiology as an 8-year-old is not just that of a minuscule adult. But similarly, actually considering that the physiology between males and females is different is just not covered in any of the clinical trials. There is some sex-based subgroup efficacy, but when you're talking about a trial that's maybe enrolled 200 people, you very rapidly lose power. No trials have reported adverse events by sex. Minority have done efficacy or safety analysis by sex, and none actually commented on this lack of statistical power. And then older adults are excluded in all trials, which is a topic in itself. The cutoff is 55, 65. And I suspect that's just because it was copied from the last ethics application, which was copied from the last ethics application. It's not because people have thought there is a reason for this cutoff. There is no reason for this. So actually in our older MS population, we don't really know what we're doing. So now on to what I think I was expected to talk about, which is female researchers in MS. There's been an awful lot about this in the scientific press over the last couple of years. I think you don't need me to stand up and tell you that there are huge gender disparities as you progress up the academic rank. It's not so much a glass ceiling as just a leaky pipeline where people are put off at every stage of the application. And there are a huge number of well-rehearsed reasons for this. One of the things, sort of thinking about actually MS epidemiology and MS treatment that I want to think about was clinical trials, and with specific thought to the fact that most of our patients are women. Most of the patients that we treat are women, but actually are we answering the right questions? So this was published a couple of years ago, and very few women on clinical trial steering committees. So what? Does this actually influence research priorities? Well, I would argue, yes, it does. Okay, I would say that actually the questions that you ask are influenced by who you are. We like to think we're scientists, we like to think we're above personal opinion, but actually the questions that you ask in a research context are hugely informed by who you are, your life experience, both to do with your sex, but also everything else as well. If anybody hasn't read this book, I would strongly recommend it to you. It's all about implicit bias within the world at large. It's not all about science, it's about everything. And you suddenly start to realize that actually the world has been designed by men. And there are so many things. It comes down to the fact that women's clothes don't have pockets big enough to put a phone in. You know, all those things that actually would be quite helpful. I'd quite like to be able to put a phone in my pocket, but none of my smart clothes have got pockets. So, and one of the things that Professor Vauban's been particularly involved in is international women in MS. And I'm sure a lot of the people here will have heard of it, certainly not everyone. And it sort of came on from the stuff around clinical trials, trying to address the problem that you can't be what you can't see. If you don't see anyone who's like you, you think, I can't do this, I can't be this. So actually to try and create an international network to overcome lack of visibility, but also on a wider context to overcome equity, well, to try and achieve equity. And that's not just about sex, actually. That's about age, that's about gender, that's about minority characteristics. And really to create more of a cohesive atmosphere, more of a positive atmosphere, to foster collaborations. One of the aspects that I've been sort of fairly peripherally involved with is setting up mentorship to address specific challenges faced by women throughout their career within MS, be that as clinicians, be that as researchers. And actually, this is starting to deliver meaningful change. So they've developed, signed memorandums of understanding with ECTRIMS and LACTRIMS to ensure equal numbers on panels. Now, from 10 years ago, this is a massive breakthrough. I remember going to ECTRIMS and seeing only men in grey suits, with all due respect to everyone in the audience, and actually being able to see women on panels, being here today and seeing, talks almost entirely by women is actually extremely refreshing. And this is working just towards age and gender as well. This is not just about gender, although that's where it started from. Also within International Women with MS, there's online meetings and opportunities for more junior researchers who may not be able to access international meetings, they may not have access to travel, to present and share learning. So opportunities to present within an international network, get feedback on work. And the online meetings are fantastic. And the other thing to any more junior people, so this is a bit of a rogues gallery, and this is just a minority of the women working in MS. There are huge numbers of women doing wonderful things in MS. And I think we have to highlight that. So it's my last slide. I think I've come in just on time. So I'd like to say thank you for listening. And I think really my key points are thinking about increasing research on actually environmental modifications to MS risk and how and why these act differentially between the sexes. It's not as simple as saying, low vitamin D increases your risk of MS. Actually uncovering those pathways, you have to think really hard about the epidemiology and learning from differences in MS susceptibility. Learning from our differences is actually what makes research interesting, and what does this tell us about the MS causal cascade, and the need to make sure that clinical research is representative. So at the moment, clinical trials are not representative of the MS populations that we serve, and we need better ways to overcome this and to think about this, but in a way that does not develop sort of drug development and drug delivery. Please go to the International Women in MS website, and please join the mailing list. You don't have to be a female to join it, you can be anyone. Join it, because there's actually lots of interesting opportunities that come up through there. And I think the final thing is just to listen to what other people are saying. Actually, sometimes the hardest thing is getting your voice heard. And if anybody reads the same, say, newspapers, I'm not sure they're newspapers as me, the whole furore about Lawrence Fox recently in the news saying, well, you're criticising me for coming from white male privilege. Well, I say that's a negative thing. And actually, thinking about, well, listening to people who don't often get the opportunity to speak up, and listening and truly hearing what they are saying is the only way that people will be able to make a difference, both in research but also more wider in the MS community. So it won't skip on. Thank you.